All right, let me get attendance real quick. Maria Barker,
I'm here.
Alexandra, Alexandra,
I'm here.
Monet,
Here.
Brandon,
Here.
Stella,
Here.
Tamara,
Here.
Kayla, Kayla Allen, Amber,
I'm here.
Rachel Crum,
Here.
Corey, Mariah,
Here.
Crystal,
Good morning. I'm here.
Paige,
Good morning. I'm here.
Jeremy,
I'm here. I was doing something.
who was that? Kayla?
Yeah.
Okay, Kayla, I got you. Rachel Moses,
Good morning. I'm here.
I never know how to say your name. Is it Taji? I don't see her either. Okay. Is it Layla Walker or
Hi, good
Leah?
morning. Lelia.
Lelia. Victoria,
Good morning. I'm here.
Lee Brown,
I'm here.
Mallory,
I'm here.
Antonio, or Antoinette. Sorry, Antoinette.
That's me, Tony here.
Okay, Angel,
I'm here.
Ashley, Morano,
I'm here.
Alicia, or Lisa. How do you say it, Alicia? Okay. So Corey Gross.
Here.
Okay. And I forgot Athea. Athea Pierce.
I'm here.
Okay. Is Taji here? Tajia, something like that. All right, so she's missing. Okay. All right. So we got a lot to go through. Now, I finished the final last night. So now I just have to make up the study guide, okay? And then I'm making up something for us to review on Tuesday. So, just bear with me. I'll try to get the study guide done today. Also, how many of you have done that survey? Okay, did you show somebody that you did it?
There was nothing to show. After it's done, it goes to a generic screen for the company. But I did it.
Okay, let me write down who did it, because I have to have a list on how many students do it. It is an ABHES requirement, so we have to have a certain percentage of the school doing it in order to still qualify for ABHES and be a school, a college. All right, raise your hand again if you did it. Okay, Amber.
Miss Shank, Maria Barker. I did it too.
Okay, Maria Antoinette, Rachel, and Brandon. Okay. 1, 2,
And I
3.
did it as well, Lelia.
Lelia.
And
Okay.
Mariah Coleman did it as well. I was too late to raise my hand.
Okay.
Alicia Kimolo did it as well.
Okay.
I did it too, Stella.
Yep. All right.
Crystal Crook did it as well.
Put down cord.
I got you, Antoinette. Who else?
Crystal.
Both the Rachels. Both the Rachels did it.
Oh, both Rachels. Okay.
Yeah,
I only
Rachel
got one
Elementary moved it.
Rachel. Okay.
Corey Dots.
And Corey. Okay.
Did you get Crystal?
Yes.
Okay.
Did you get Monet?
Yes. Okay. Actually, I don't need names. I just have to have a number to send in that this many students of mine did it. All right. So the other thing is you all got, if you failed the test, you got a course project or course performance tracking sheet that I emailed you. Not everybody has responded to me. You were supposed to meet with me if you get one of those and schedule a time. I only had one person yesterday, and I only have one signed up for today. And then I have one for Friday. The reason why is if you fail the class, when they're letting you back in, they will look at if you met with me. So hopefully none of you fail, but we want to make sure that you do meet with me if you received one of those so that when you want to come back in, if you fail the class, you will be allowed to come back in. It's not that you won't definitely, but they look at that when they're looking at how many students they can have come back. So, I mean, it's in your plus to meet with me. Okay, so we are on chapter 24, which is hematological and neoplastic. This is quite a long chapter. Did we start on it at all? We didn't start 24 at all, did we?
I
We
don't think
did.
so. Do we?
Okay, so we did sickle cell anemia.
You left
Yes.
off on the clotting disorders.
Okay, the hemophilia. Okay, let me find that. It's in it. We did iron deficiency anemia. We did sickle cell anemia. We did thalassemia. Oh, okay. So we're on thrombocytopenia. All right, let me find that. Okay, so the ones that we are going to do are the idiopathic thrombocytopenia purpura. I'm not going to test you on DIC. You're going to get that. Well, you should have had it in med surge, and then you're going to get it again when you go to leadership. And then the most common of the factor deficiency is hemophilia A, factor 8. So I'm going to do that one. The other ones, yes, are there, but they're not as common. So idiopathic thrombocytopenia purpura. They have petechiae, pinpoint hemorrhages occurring on the body that do not blanch to pressure, and they have larger purplish areas of hemorrhage in which the blood clots underneath the skin. There is a picture in your book of a baby with it on 861 if you want to see the picture. It's an immune response following an infection that produces anti-platelet antibodies. So it destroys the platelets, which is why they have the bruising and the petechiae. It's not that common, but I have seen it. So we just need to admit them, okay? And then they usually recover spontaneously within a few months, but we have to keep an eye on them. We give them corticosteroids and IV immunoglobulins. IV immunoglobulins, and then corticosteroids. If it is severe, then we have to give a platelet transfusion. It usually follows a viral infection, but any infection can cause it. The petechiae and purpura and bruising progress rapidly within the first 24 to 48 hours. And then while we are checking them, we have to do our clotting studies. Who remembers what labs we are drawing when we are doing clotting studies?
Is it a PTINR?
PTT, and what's the other one?
But INR, is it the INR?
INR. Yep. PT, PTT, and INR. So PT is prothrombin time. PTT is partial thromblastin time. And then the INR is international normalized ratio. This is on page 860. Where is hemophilia? Aplastic anemia. Huh. Well, that's weird. I'm missing hemophilia in my PowerPoint. Okay, so hemophilia is an X-linked recessive disorder. Females are carriers. Male children actually have the disease. So they're missing factor 8 in hemophilia A, which is a clotting factor. So their blood does not clot. It can range from mild to severe. When bleeding occurs, because of the deficient factor, the fibrin will not solidify, therefore they don't clot off if they get injured. The goal is to prevent bleeding. They especially bleed in like their joints. So these children should avoid football, riding motorcycles, skateboarding, any activity that has a high potential for injury. So they should do like swimming, running, tennis, things where you're not having contact or falling a lot. If bleeding occurs, usually they can do it at home. If it's severe, then they have to go in the hospital. And what you do is you just administer factor 8. So when it's in the home, they give an IM injection. And then if it's severe, then we have to give it slow IV push. So it's nice if they can catch it early and the parents and caregivers can administer it. No, I'm sorry, it's not IM in the home. It's still IV infusion. So these kids probably have a port if we're giving factor IV in the home.
Mrs. Shank,
Yes?
I had a friend growing up who had hemophilia, and his little sister did as well. And she passed away when we were in like elementary school, but he lived until our mid 20s. Do people with hemophilia always pass away early?
No. Remember, it goes from mild to severe. So he had to have severe. Okay. So if
So
it's
people
mild
with
to moderate, no, they're going to live a real long time. If it's severe, then they're less likely to live a long time. So I guess it just depends on how bad. In mild cases of hemophilia A, they can just use desmopressin to stop the bleeding, and you don't have to administer the factor 8. Plus, back then, were they administering factor 8 IV in the home? Yeah, see? So now that we can do that, there's not the complications of this bleeding because parents can give it right at home and stop any damage. So,
So forgive me.
more,
Does the factor A kind of change their coagulation from then on?
no,
Guys, I'm in
they
class.
have to have it every time they have an episode of bleeding, every single time. That's why you want to make sure that these kids are not injured, because you got to have that factor 8 every single time they have a bleeding episode. So every time they cut themselves, every time they get a bruise, you've got to give that factor 8 IV. So wrestling, soccer, diving, football, make sure that when they're riding their bicycle, they have helmets, knee pads, elbow pads. Toddlers, you're going to make sure they wear soft helmets, pad their knees, make sure there's carpet, make sure all the corners have those soft covers on them. If they're going to have any kind of oral surgery, we pre-medicate with Amicar. So desmopressin, if it's mild, you got to give factor 8 slow IV push. If it is anything more severe. Okay, so the next one is cancers. Okay, so with children, it's usually cancers that affect the tissues. leukemia, lymphoma, like your Hodgkin's disease, blood, lymph, brain, bone, kidney, and muscles. There's little known prevention for when it's a child. The environmental factors don't matter when they're children. Metastasis is often present at diagnosis when they're a child. So it does respond to treatment very well with children, but it tends to metastasize faster with children. So these are the common ones. Leukemias, ALL is the most common leukemia in children. Okay. Acute lymphoblastic leukemia. That is what ALL is. Acute lymphoblastic leukemia. Hodgkin's disease and non-Hodgkin's lymphoma, that tends to be in the teenage years when they're diagnosed. Brain tumors, the most common brain tumor in the child is the medulloblastoma. They can get these other brain tumors. Then they tend to get neuroblastoma, osteosarcoma, Wilms tumor. That rhabdomyosarcoma is in multiple sites, and then one called retinoblastoma. So these are your common cancers in your kids. So we want to know the maternal history, recent illnesses, sleep-wake patterns, elimination, family history, typical diet, exposure to lead. Those are all the things that we're going to assess when we are trying to see if they have a hematological or neoplastic disorder. Have they been exposed to anything? Infectious disease history. This is for aplastic anemia. Do they have nosebleeds, gingival oozing when they brush their teeth, increased bleeding with menstruation, headache, fatigue, any ecchymosis, a lot of bruising, petechia, purpura, oral ulcerations, tachycardia, and tachypnea? All of those, if we know there's not like an infection going on, those are the things that we're going to be looking for. These are your common tests. They're pretty much the same as you would do on anybody when you are checking for a bleeding disorder. I'm not going to test you on that. Here is some lab values. I'm not going to test you on that. Okay. All right. Okay, so the other things we're going to look for are fatigue, pain, impaired physical mobility, ineffective health maintenance. They're getting sick a lot. Anxiety and ineffective coping. This is just terrible. This cannot be my right PowerPoint. All right, hold on a minute. I know it's early, but go ahead and take a quick break so I can find the right PowerPoint. Huh. Maybe I don't have it, because that is the one from Lippincott. I thought I had one I redid. Hmm. Sorry about that. I don't know what happened. So a lot of them I redid. Some of them I never got to redo. Evidently I didn't get to this one, so it's the Lippincott PowerPoint, and that was it. So with ALL, of course, it's going to be chemotherapy. The pathophysiology is unknown. They think genetic and chromosome abnormalities have a play in it. You have abnormal lymphoblasts.
Can you share your screen?
I can't. That's
Oh,
what I just said.
I wasn't sure if you were still going to use the other PowerPoint.
I couldn't find the other PowerPoint that I redid. So all I have is the Lippincott one. So if you go to your book, page 866, you can open your book, chapter 24. Now, the way that they did it now, with the being in bright states, can you guys highlight anymore? Remember in Lippincott, you could open your book and highlight and all that? Can you do that this new way?
I actually think, yeah, we can. So I think I highlighted 6.
Okay, so just go to Brightspace and open chapter 24 and then highlight as I read along. Let me know when everybody's ready. Page 866 is acute lymphoblastomic leukemia. So it'd be chapter 24. How many people have it up yet? Oh, one? Okay. Give you a few more minutes to get in it. Okay, I got another one in. Okay, that's 3 are in it. Now, I know some of you guys are going to have a little bit of trouble with your cameras if you go on to Brightspace, so I'm not going to worry about if your camera's on or not at this point. I just want you to follow along with the book. We got enough.
I have to go on. I have to go onto my laptop, so just give me 1 second. I'm switching over to the laptop.
Okay. How's everybody else doing getting into the chapter? We're getting there? Okay. Got a couple more that got in already. Okay. So we're on H66, acute lymphoblastic leukemia. So we need to restore normal bone marrow function because that is where our blood cells are made. The bone marrow becomes unable to maintain normal levels of RBCs normal level of WBCs, normal and normal platelets. So they have anemia, neutropenia, and thrombocytopenia. After it's in the bone marrow, it then can go into the lymph nodes, the liver, and the spleen. So they have lymphadenopathy, and then they have splenomegaly and hepatomegaly. So their spleen and their liver enlarge. If it gets to their brain and they start having CNS, central nervous system, then that's not good. We want to treat it before it gets to that. Okay? So under their physical exam, they're going to have a fever, petechiae, purpura, bruising. They might have adventitious lung sounds because of the, and they're going to get like pneumonia because without the white cells, they can't fight off infection. And then we're going to have the swollen lymph nodes, enlarged liver, and enlarged spleen. We do a bone marrow aspiration. And they do a lumbar puncture to tell if it has infiltrated into the central nervous system. Sometimes they require blood transfusions because of the anemia. And then, of course, we need to reduce their pain and we need to reduce all the symptoms that go along with getting chemotherapy. The nausea, the vomiting, the mouth sores, the hair loss. So the next one is lymphomas, Hodgkin's disease. These are lymphomas or tumors in the lymph tissue. Remember that the spleen is part of your lymph system. It has a double duty. So we have Hodgkin's and non-Hodgkin's. Hodgkin's disease is malignant lymphocytes grow in the lymph tissue. It starts in a general area, and when you do the testing, it's Reed-Sternberg cells. The presence of Reed-Sternberg cells. That is what is the definite diagnosis for Hodgkin's disease, is the Reed-Sternberg cells they find when they do the biopsy of the lymph nodes. They have seen Hodgkin's disease related to kids who have the Epstein-Barr virus. Epstein-Barr virus causes mononucleosis, is one of the diseases that the Epstein-Barr virus causes. There are some other infections, but mono is usually the one that we associate with Epstein-Barr. Hodgkin's, like I said, is adolescents and young adults. And then it is put into staging on how far along it is and how many lymph nodes are infected. Chemotherapy and radiation may be used. The symptoms are recent weight loss, fever, night sweats, anorexia, malaise, fatigue, or pruritus. Then after that, you start noticing the enlarged lymph nodes. Non-Hodgkin's lymphoma is a mutation of the lymphocytes. It tends to affect the lymph nodes that are deep in the body. Then it spreads into the bloodstream. Non-Hodgkin's is aggressive malignancy. So non-Hodgkin's lymphoma is worse. Remission is done with chemotherapy. And then they have to continue to have maintenance chemotherapy for 2 years. It progresses rapidly. They have painful lymph node swelling. Brain tumors are next. Nobody knows why kids get brain tumors. It depends on the location and the extent of the tumor to whether they can surgically remove it and do chemo and radiation. Chemotherapy does not always pass the blood-brain barrier, so therefore chemo is not always effective. Okay. We have to look for hydrocephalus, increased intracranial pressure, and the negative effects of radiation. So kids with brain tumors, there is a lot of symptoms because it's based on where it is in your brain. Nausea, vomiting, headache, unsteady gait, blurred or double vision, weakness, atrophy, motor abnormality, hemiparesis, seizures, swallowing difficulties, behavior or personality changes, irritability, failure to thrive. We might see strabismus or sunsetting eyes because of the pressure from the tumor. MRI, CT scan, and lumbar puncture. If it's possible, they're going to try to remove as much of the tumor as they can. The only thing I'm going to say about the neuroblastoma is it arises from embryonic neutral crest cells. So somehow we still have embryonic cells from utero. Osteosarcoma is bone cancer. And again, that is another one that's common in children. Again, they think it arises from embryonic tissue that is in the bones. Removal of the tumor is the first choice, and then they get chemotherapy after that. There is a possibility of amputation, but we try to salvage the limb. But if it's going to take their life, we're going to amputate. Ewing sarcoma is a highly malignant bone tumor, but it's rare. That's all I'm going to say about that one. We're going to skip the rhabdomyosarcoma, and we're going to go to Wilms tumor. Wilms tumor is the kidneys. It happens between the age of 2 and 5. It only affects usually one kidney, one or the other. So by removing the kidney, the child can still function with one kidney. The thing with the Wilms tumor is it's encapsulated. As long as we don't break that capsule, it doesn't spread. It won't go and be metastasized. So we have to make sure that nobody does any palpating of the abdomen or the back where the kidneys are. Because if they break that capsule, then it will metastasize rapidly. We want to get it diagnosed and remove that kidney before it metastasizes anywhere. They have 25% of children will have hypertension. You usually notice the mass. It's a visual mass where the kidneys are. Kidney, or an abdominal ultrasound, CT scan, MRI. And then, like I said, we just remove the entire kidney. Retinoblastoma is congenital. They're born with it. It's highly malignant. It arises from embryonic retina cells. The children or parents start noticing that white spot in their eye. And then that's when they take them in and it's diagnosed the retinoblastoma. That we don't want it to metastasize to the brain or the lymph nodes. So our treatment is you do inoculation. You remove the eye. So chapter 25 is immunity or immunological diseases. Actually, I think I might just skip this chapter. What else is in here? Oh, no, we got to do lupus. There's juvenile arthritis in this one also. That wouldn't have been in it. Actually, do I have any questions on lupus?
It's the worst.
Yeah, it is. Oh, yep, and arthritis is in here. Okay. So let's go through and find lupus. There we go. Okay, can you see the lupus? Is it showing it? Okay. So, yes, lupus can happen to children. A lot of times we think of it as an adult disease, but there are kids who get lupus, and it happens between the ages of 9 to 15 when you get it as a child. The person who said it's the worst, was that an adult or a child?
I got diagnosed with it as a teenager.
You did get it as a child.
Yeah, but I still like it's gotten worse as I've gotten older though.
See, I have only taken care of adults that got it as adults. I've never
Yeah.
taken care of a child with lupus.
Yeah.
But yes, it is the worst. So it's a multi-system autoimmune disorders. You have exacerbations and remissions. Our goal is to have less and less exacerbations. You're going to do a CBC platelet, white count is decreased. Everything is decreased, basically, okay? And the ANA titer is one of the tests we do along with the SED rate, and that is usually positive in someone who has lupus. One of the classic signs of lupus is the butterfly rash on the face. Because it looks like the wings of a butterfly and then their nose is red, they call it a butterfly rash.
Mine always got really hot. Like my cheeks were like 106 degrees.
Oh, wow. So it's hot to
Yeah.
touch your butterfly rash. Okay. Unfortunately, it affects every organ in the body, including tissues, muscles, and organs. It's chronic. Um, and we have to treat it with steroids, anti-malaria agents, and NSAIDs. Now, I can't remember the name of it offhand. What is the anti-malaria agent that they were trying to give to COVID patients? Anybody remember that drug?
Is it the chloroquine?
So everybody was trying to get it to, in case they got COVID. And then we were like, didn't have enough of it. And lupus, people with lupus have to have that drug.
It's
And
hydrochloroquine.
yes, that's what it was, the hydrochloroquine. So it became a big issue. And they didn't even prove that it did anything for COVID. But people were asking their doctor for it, and then it became a shortage. Well, people with lupus need that drug. It keeps them from going into an exasperation. It affects, in the end, it can affect the kidneys and develop end-stage kidney disease because of the high doses of the corticosteroids, and then dialysis may be necessary. So they have alopecia. What's alopecia?
Loss of hair.
Loss of hair. Anemia. This is like a really bad PowerPoint. God dang it. I should have tried to get through them all. Nephritis, fatigue, arthritis, arthralgia, all their joints hurt, pleurisy, Raynaud's syndrome, seizures, skin rashes, stomatitis, and thrombocytopenia. So, in addition to the medications that we're going to give, if it gets severe, we may need to give immunomodulators. I don't even know what immune modulators are at this point. Because their photosensitivity, they need sunscreen when they go out in the sun. And as she said, it's a terrible disease. They're in a lot of pain. They can't do a lot of things. It limits a lot of their ability to walk and do everyday stuff. Idiopathic arthritis, juvenile idiopathic arthritis is your rheumatoid arthritis, but now you're getting it as a child. So it's the same symptoms as adults. The problem with it happening as a child is as you get older, the contractures are more because you started at such a young age. You know how the joints in older people with arthritis get really big and then they're like crippled? Well, that happens at a younger age to these people because they started having arthritis as a child. Methotrexate is a chemo drug, and they do give that along with NSAIDs, corticosteroids, and anti-rheumatic drugs. We want to make sure that we're using, range of motion, exercises, splints, anything like that to, keep them from getting contractures in their joints. And then, of course, we want to promote a normal life. All right, we're going to take a quick break because that's all we're doing out of that chapter so that we can get into chapter 26. Okay, I'm back. So for 26, we're going to do the thyroid gland. And then we're going to do diabetes. That's it out of this chapter. Okay? So this is just a review of your endocrine system. All your glands that included. So a lot of these are done. We do a newborn metabolic screening. They do test the baby's thyroid gland. But these are all the different tests that we can do when we are thinking that there's some kind of endocrine disorder. Medications, hormone therapy for the growth hormone, levothyroxine for your thyroid gland, corticosteroids, desmopressin, and of course your hypoglycemics or your hypoglycemics to bring down your blood sugar. Blah, 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 blah. Do. Okay, that's pituitary. Thyroid. So we can have hyperthyroidism, but that is very rare in children. Most of the time, children get hypothyroidism. People with Down syndrome, or if mom already has hypothyroidism. So we have a decrease in our thyroid hormones. That's the T3, T4. I hate saying them. Thyroid, blah, blah. We always just call it T3, T4. And then your TSH is your thyroid stimulating hormone. Okay? When they have hypothyroidism, just like in adults, it's lifelong thyroid supplementation. Levothyroxine, just like we give the adults. So this is a comparison between your hyper and hypo. I always remember that hypo, everything in your body slows down. So that's why you have cold tolerance, constipation, weight gain, tiredness, fatigue. And then in children, they have decreased growth when they have hypothyroidism. Hyperthyroidism, everything starts acting more than normal. Nervous, anxiety, diarrhea, heat intolerance, and weight loss. So when a child has congenital hyperthyroidism, the thyroid gland did not develop. So it does not produce the thyroid hormones to meet the metabolic needs and the growth and development. It's not that common, but we have to make sure that we find it early, which is why it's done on a newborn screening, because it will delay their physical growth and their development. It will also cause intellectual disabilities if we do not get it treated. Newborns don't have a lot of symptoms. That's why we have to do the newborn screening. So Synthroid, levothyroxine are the drug of choice. And then we just need to monitor their levels and make sure that they are developing properly. Thyroid storm is something that anybody with thyroid problems can go into. And the thyroid storm is when too much is released all at once, too much thyroid hormone. So we have hyperthyroidism, but when you go into a storm, a bunch of it is just released all at once. Restlessness, irritability, fever, diaphoresis, and severe tachycardia. Hyperthyroidism, acquired hypothyroidism. Disorder associated with autoimmune diseases, Hashimoto's disease, which is a thyroiditis. All right. So now we're going into the diabetes. I know you guys know a lot about diabetes, but there are some things that are just very specific when you are teaching and dealing with children who are diagnosed as a diabetic at the age of 4. So, type 1, remember, is we don't produce enough insulin. Type 2 is insulin resistant. We have insulin, but our body is not able to use it in our cells. That's type 2. We are getting a lot more kids with type 2 diabetes because of our lifestyles nowadays. Gestational diabetes during pregnancy can always, lead you to diabetes later in adult. Kids with cystic fibrosis, because of glucocorticoid use, Down syndrome, they are prone to becoming a diabetic. Type 2 is usually a family history. Type 1, it's not usually runs in the family. They get it, you know. Remember your 3 P's for diabetes: polyuria, polydipsia, and polyphagia. Increased hunger, increased thirst, increased urination. Those are usually the signs that brings the child in, that then we diagnose with childhood diabetes. They seem to think that it is an autoimmune disease when we get it as children. Um, And then on page 940 in your book is a really good chart related to the child and the family implications and the nursing implications of when you are dealing with children and the age groups. So that would be a really good thing to read. Because if a toddler has it, we have inconsistent food intake when they're toddlers because they're picky eaters. They don't always eat. Toddlers are like eat and run type thing. So we have to worry about hypoglycemia in that toddler. Then you have to decide, is it like normal toddler behavior or are they going hypoglycemic? And then parents become overcautious when their little child has it. So again, it becomes, how do I discipline my child yet take care of him as a diabetic when he is a toddler or preschooler? Preschoolers, remember they have magical thinking, so they might have thought that they did something to cause this. They lack the developmental skills to be able to check their blood sugar, give them their insulin, or monitor their food and activity. School age children is when we start letting them participate. We want them to start around 6 to start giving their injections, deciding where to get their injection, test their sugar, start, looking at what foods have high sugar content in them or carbs. And then, of course, they struggle with the fact that they are different than their peers. Adolescence becomes a problem because they want to be like their peers. And of course, adolescence is when they like junk food. So again, making sure that they are, eating, following their diet, checking their sugars, helping them as they struggle for independence and peer groups. Most of the question on diabetes that I have on the test are related to that table 26.4, related to the different age groups getting diabetes and having to deal with diabetes in the different age groups. So 940 table 26.4 is something you specifically want to look at. You should already know the signs and symptoms versus hyperglycemia, but if you need to review it, it's on page 947. And then remember that they need to have some kind of glucose on them at all times in case they do go low. And again, the problem with starting diabetes at such a young age is they are more at risk for the complications earlier in life. The retinopathy, the kidney disease, the neuropathy, all of those, and the effects on your vessels, causing you increased risk for heart attack and stroke. All of those are going to be worse as they get older because they started at such a young age. Diabetic ketoacidosis, anorexia, nausea, vomiting, lethargy, decreased skin turgor, Kussmaul respirations, and fruity smelling breath, ketones in their urine and blood, and tachycardia. We got to have the child and the parents know the signs of diabetic ketoacidosis, because if it's not treated, then they have coma and death. Promoting growth with the child that has that congenital hypothyroidism. These kids need to be measured in growth chart at regular intervals, probably more than we do when the child is A normal, now we always do the growth charts frequently in that first year. Then they go at 15 months, 18 months, and 2 years. But then we start doing it only yearly. These kids will need to be seen more often than a yearly physical to record their growth. Monitor for signs of the hyper and hypofunction, and they need adequate rest periods. I am not going to question you about insulin. So this was all the complications that we just talked about. The two that specifically go to PEDS is the failure to grow and delayed sexual maturation. Otherwise, all of these are the same that we get as an adult. So for the test, it's hyperthyroidism, and diabetes out of chapter 26. "27 is genetics. The biggest one is Down syndrome, okay? Because it's common in Down syndrome is a little bit more common. So we need to know about Down syndrome. If you need to go over, I'm not going to test you on it, but how we get the dominant inheritance pattern and the autosomal recessive. Okay. So genetic testing, pre and postnatal, we can do for Down syndrome. Echocardiogram is done because most people with Down syndromes, babies, have heart defects, ventral septal defects being the most common one. Genetic testing, these kids are prone to sleep apnea because of their enlarged tongues and their flat face. So we do sleep apnea. A lot of times they have vision and hearing problems. They're prone to thyroid problems. And then we're doing cervical radiographs for their spine and an ultrasound to find any other malformations they may have with Down syndrome. So, what the heck? These are just terrible PowerPoints, aren't they? There we go. So with Down syndrome, it's called trisomy 21. They have an extra part attached to their 21st chromosome. So that, when you do genetic mapping, gene mapping, that is what it shows. You can be mild Downs all the way up to severe. There is always some degree of intellectual disability. So with their facial features, they have slanted eyes, flat nose, and like a rounded face. And they have low set ears. don't know if I put my Down syndrome handout in there or not, but I will definitely upload it if I didn't. So these kids will have feeding problems a lot of times. They have gastrointestinal problems, recurrent infections. They get a lot of otitis media with Down syndromes. A lot of times they have eustachian tube dysfunctions, which is what causes them to have the recurrent otitis media. Some of the things that make them more at risk to have a Downs is maternal age, older than 35, and then lack of prenatal care is another one. A lot of times they can diagnose the child with an ultrasound because the facial features show up abnormal when they do the fetus ultrasound. So, like I said, the most common congenital heart disease with Downs is the VSD, ventral septal defect. They can have other ones, so we need to pay attention to that. Multidisciplinary teams need to be taking care of the child with Downs. You know, they're going to need speech, dietitian, physical therapy, occupational therapy. Sometimes psychologists are needed. They're going to have a cardiologist, an ENT doctor, all kinds of doctor's visits when they have Downs. And again, early intervention is important because of their delayed development. So we want to start encouraging and accelerating therapies and school with them early so that they can reach certain milestones and then get as far as they can as far as cognitive and physical development. They're short in stature. Sometimes they have broad, short fingers. I'll send that handout if I didn't already. So actually, Down syndrome is the only one in here that is really prominent that you're going to see and that you need to really know about. What chapter was that? Oh, that's in the same chapter. No. Oh, where's 28? Hmm. In chapter 28, we need to do ADHD and autism. So a lot of things that affect your children's behavior is, of course, we saw when we did some of the first chapters. Um, Nutrition, their physical health, their developmental, their genetics, environment, family, individual temperament, and the caregiver's response to behavior. Autism, there is a checklist for autism in toddlers, chat, or a modified one, social communication questionnaire, and persuasive developmental disorder screening. So if we think a child has autism, those are some of the tests that we're going to run or do with them. Okay? So when we have a child with behavior issues, whether it's autism, whether it's ADHD or some other psych disorder, we need to set limits, hold them responsible for their behavior, don't argue or bargain, consistent caregiver and routine, low pitched voice remain calm, redirect them, ignore inappropriate behaviors, praise them for self control, and only use restraints when absolutely necessary. Well, we should do fetal alcohol syndrome, I guess. Fetal alcohol syndrome, they have a low nasal bridge with short upturned nose, flattened mid face, and long philtrum with narrow upper lip. So that little thing in that little space in between our top of our lip, that is long. Microcephaly, failure to thrive, hearing loss, poor coordination, and skeletal abnormalities. These kids usually have some kind of cognitive delay, and some of them have like tremors when they are born. These are warning signs of autism. The baby doesn't imitate, lack of interest, eye contact abnormalities, delayed language development, failure to develop symbolic imaginative play, and difficulty with minor changes or transitions, whether they're starting somewhere new, like a school, a daycare, or whether you're just changing their bedtime. Anything like that bothers the child with autism. So, with intellectual disability, we can go from mild to moderate, severe to profound. So, etiology for autism. They're not really sure what causes autism still to this day. They think there might be genetic makeup, brain abnormalities, altered chemistry, a virus, a toxic chemical. Some people thought it was the mercury used in vaccines. They pretty much got wiped that out as a cause, but nobody really knows why a child develops autism. Then with ADHD, we have 3 different types of ADHD. You're hyperactive, impulsive, inattentive, or you've got both. All right, so for autism, again, it is on a continuum. Kids with autism have a lot of problems bonding with their parents. They have social problems. They don't relate to the world around them, is what it is. So there's a lot of different things we can do for the child with autism. They also have to that self-stimulate themselves, whether they are doing this all the time or hand flapping or something. They self-stim themselves when they have autism. Well, your book is not really good about autism. All right, I'm going to find a video that I really like about autism. See if I can find it. Forgot the kid's name. Huh, we might have to watch something else. I can't find the one I like.
Always know what you'll pay upfront. No surprise prices, no hidden fees. And for a limited time, Wegovy for only $1.99 a month.
What are the symptoms of autism?
All right, we'll try to watch this one.
Symptoms and signs in children and adults. So if you notice any of these signs, it's a good idea to talk to your child's doctor for advice and possibly a formal evaluation. So early signs in children include social interaction difficulties. One of the earliest signs is trouble with social interactions. So for example, your child might not respond when you call their name, or they might not make eye contact with you. Babies typically start smiling and making joyful expressions around 6 months old, but a baby with autism might not do this. By 9 months, babies usually engage with back and forth interactions like making sounds or facial expressions with others, but this might be absent in a baby with autism. The second thing you might notice are communication delays. By 12 months, most babies start babbling and using gestures like waving or reaching out. If these milestones are missing, it could again be a sign of autism. By 16 months, if your child isn't saying any words, or by 24 months, they're not speaking in simple 2-word phrases, these could also be signs. The third thing is loss of skills. So another red flag is if your child seems to lose skills that they once had, such as stopping talking or engaging socially. Now, there are also some specific behaviours to watch out for. So the first is repetitive actions. Children with autism might line up their toys in a specific way every time they play or insist on following certain routines to the letter. Even small changes in these routines can cause them to become very upset. You might also notice some unusual interests or sensory sensitivities. Now, let me explain this. Some children with autism have very intense or unusual interests. They might also be extremely sensitive to sounds, textures, or lights, or engage in sensory seeking behaviors like sniffing objects or looking at things out of the corner of their eye. Now, some people ask what causes autism. Well, autism doesn't have a single known cause, and it's likely that a mix of genetic and environmental factors play a role. Researchers are still learning about what exactly leads to autism, but they know that it involves changes in how the brain develops. Some other people ask, is it genetic? Well, yes, genetics can play a part. In some cases, specific genetic changes or syndromes are linked to autism, but these account for only about 10 to 20% of cases. Now, if one child in a family is diagnosed with autism, their siblings are at a higher risk of being on the autism spectrum as well. Other people ask, do vaccines cause autism? The answer is no, vaccines do not cause it. This idea has been thoroughly researched and debunked. Sometimes parents notice signs of autism around the same time that the child receives vaccinations, but this is just a coincidence. Numerous studies have confirmed that there is no link between vaccines and autism. So the really important thing is to make sure that your child stays up to date with their vaccine schedule. Now, there are certain risk factors for autism. So the first is if the birthing parent is 35 years or older. Secondly, if the birthing parent took certain medications like valproic acid or thalidomide during pregnancy, if there has been a premature birth or complications during delivery, having a sibling with autism, as well as certain genetic conditions. But just because one of these things happened or is present does not mean your child will necessarily develop autism. There are also some complications that can come with autism or challenges. These include feeding and sleep issues, digestive problems, so GI issues, epilepsy, ADHD, anxiety and depression, as well as other mental health conditions like OCD or bipolar disorder. Again, just because your child or yourself might have autism doesn't necessarily mean you will develop these problems, but there is a certain link with them. Now, it is important to flag that autism is not just a childhood condition. Many adults live with autism, sometimes without realizing it. Common signs in adults include social challenges, so it might be hard to understand what others are thinking and feeling, or you might feel very anxious in social situations. Making friends can also be difficult, and you might prefer being alone. You might also have literal thinking, so you might take things very literally. So phrases like break a leg, meaning good luck, might be confusing. You might also find a strong need for routine. So having the same routine every day can be very important, and changes in this can cause a lot of anxiety. But again, this can overlap with other conditions. Now, autism can sometimes look different in women. They might be better at hiding the signs of autism, often by mimicking the behavior of others to fit in. This can make it harder to recognize autism in women. Women might also show fewer repetitive behaviors and might appear to cope better in social situations, even if they're struggling internally. Again, this will be different for everybody, but it is something that has been picked up in research. So what should you do if you suspect autism? Well, you might think that you or your child might be on the autistic spectrum, and it's important to talk to a doctor or a specialist. Now, getting a diagnosis can open up access to support and resources that can make life easier. Please stay tuned for a full separate video on the channel in which I'll cover how to get a formal diagnosis and what this will typically involve.
So that's autism. And like I said, there is a spectrum. In ADHD, when we worry about a child with that, they don't tend to listen, and they have hyperactivity. So medication, especially when they start school, is the most important for ADHD. Some of the signs are on page 1001, box 28.3 for ADHD. They don't pay close attention. They make careless mistakes at school, difficulty paying attention to tasks or play. Don't listen, don't follow through, don't complete tasks, don't understand instructions, difficulty with organization, easily distracted, forgetful, fidgety and squirmy, often out of their seat. Their activity is inappropriate to the situation. They cannot engage in quiet play, talk excessively, blurt out answers, difficulty waiting their turn. Those are all signs of ADHD. Most of the time, it does not get picked up until the child is in school, and then, they can't sit in that seat and participate in the lessons. We need to get it diagnosed, and we need to know whether it's a learning disability or actually ADHD or just attention deficit without the hyperactivity. The medications, are Ritalin, Concerta. There's a whole bunch of newer ones out there now. Usually, we only want these childs to take these medications when they're in school and not take them like on the weekend. Behavior modification is another one that helps these kids. And the parents and the child need a lot of support. They deal with psychologists, psychiatrists, to try to get them through school, to try to get them through life. These kids are not just have it when they're kids, it develops into adulthood, and the medication has to be always on them. Um, all right, take another break, and then we're going to decide what we're going to do. All right, I'm back. Every majority of people back, so I can make sure that I say this to everyone.
I'm back.
Okay. So, due to the fact that I did not have time to fix these PowerPoints, and you saw how bad Lippincott's PowerPoints are, which is why I usually redo them, I'm going to let you go now because I'm going to make a review PowerPoint for Tuesday that will help you guys pass the final. Okay?
Thank
So,
you.
in order for me to have time to get that started, I'll let you go now. Now, I have 2 people signed up to meet with me. Can you do it now, or do you still want to wait till 2 and 3?
I can meet now.
You can stay on now?
Yeah.
Okay. All right. And then I forgot who the other one was that was signed up for late this afternoon, but all right. So the rest of you guys get your work done, and I will work on a review for us.
Thank you. Thank you so much.
Have a great day.
Thank you. Have a good day.
Thank you so much. I'm coming right now, honey.
Appreciate you.
So the
I'm
only
on my
one
way
that should be
upstairs to go
on
out
with
my
you right
laptop.
now is Kayla, right?
Yeah, I'm on my phone and laptop. My laptop is in the house, and I'm outside. I gotta go out in the house and turn off my laptop. But I'm logging out my phone now.
Okay.
Right.
Let me, what did I do with my sheet where I put everybody's who I'm meeting with? There it is. Okay, Mallory and Kayla Allen are the 2 that are supposed to stay on.
Miss.
Rachel, pick a time.
Okay. Whatever
So
works for you. I have
how
to.
about, let's see, what time is it? 12? Let's do you at 2. Come back at 2.
I actually have to take my son to PEDS gastro for celiac disease at 2. Can I do 3? I'm sorry.
Fine. All right. So I'll see you at 3.
All right. Thank you.
Bye.
Bye.
Kayla, are you on? You know if I should start with you, Mallory, or all right, Mallory, you want to get started on yours?
Yeah, we can start.
Okay, hold on. And then I'll do Kayla after that. There you are. Can you see that, or do I need to make it larger?
I don't see anything on my
Oh, I gotta
screen.
share my screen, duh.
I can see it.
Okay. So you did get that one right. Okay. So the 2 hours post tonsillectomy. I would have thought that you all knew this by now, but milk makes mucus thicker.
Okay.
So we don't ever want to give milk after a tonsillectomy. And it should have been in your book. So it was just crushed ice.
Yeah, I was between the crushed ice and the milkshake because in my brain I thought of the crushed ice being sharp.
Ah.
So those were the two that I was between. And
Well, I guess because when they're in the hospital and we use crushed ice, it comes out in little round things.
yeah, it's like shavings or the round.
Yeah.
Yeah, but in my brain, the crushed ice I thought of being sharp. That's why I didn't choose that one.
Okay. But you were right. The orange juice would have burned, and the
Yep.
cranberry juice is red.
Yep.
Bacterial meningitis. This was administer antibiotics.
Yeah, it was the when available that threw me off.
I dropped this one because the GI manifestations we didn't go over, and we didn't go over mood. So you really couldn't get it all the way right because we didn't talk about those two things in here. The rest of them we all talked about. So I did drop that question. So you got all the points for that one.
Okay.
This one again, I dropped, and wow, you would have gotten, you were one person that got it right. But I did end up.
I worked cardiac transplant, so I'm very familiar with digoxin.
Oh, only like 4 people got this one right, so I had to drop it. But, it's an important drug for the NCLEX, so I'm glad you knew it. Okay. So this is a 3-month-old. The visual analog scale was the one that was like a number line, and they put
Okay.
it through the number line. So it was the flat scale.
Okay.
Okay, so this kid is going to have, increased intracranial pressure. Okay. So what one did you miss? You got that one. Ah, you missed the head circumference.
Yeah.
That's the one you missed. So if you're checking that fontanelle for a bulging fontanelle, increased, he's only 3 months, so his head can expand. So you got 2 points for it instead of all 3 points because you should have added head circumference along with the 2 you picked. And this one you just had to know. This was Koenig's.
Okay.
Okay. I ended up taking 2 answers, but not the one you picked. I ended up taking patent ductus arteriosus and trichology of Fallot. Tetralogy flat is a mixed one, but it does do increase pulmonary blood flow. So if you picked either one of those, I took it. But corrotation of the aorta is an obstruction. Blood isn't going through at all. It's closed off. So when blood, our already oxygenated blood is going back to the lungs to pick up more oxygen, it's called an increased pulmonary blood flow. So the answer was patent ductus arteriosus.
Okay. Yeah, as soon as I clicked continue, I'm like, I got that one wrong.
Yeah.
And I realized it as soon as I hit continue.
So I took tetralogy flat because I can see where some of them were thinking that this part did it, but because it's 4 different things, it's actually called a mixed one. But I did take that answer. So this was the tetralogy flat. So you got the ventral septal defect. The thing that everybody was getting wrong was the overriding aorta. Okay. With that one, if we kind of go back and look at the picture, the aorta is over both the left and the right ventricle. So
Okay.
the answer was the last one, because it says overriding aorta receives blood from both ventricles.
Okay.
So that was the one that you missed on that one. What did you get, Mallory?
A 74.
Yeah, so you did pretty dang good. And you're still passing the class with a B.
Yeah. Last week was a hard one. My husband has leukemia and he was having some issues that I was dealing with, so I didn't get as much study time.
Oh, I am so sorry to hear that.
He's doing good, but with the weather change and his increased activity at work, it's been a tough one.
Is the chemo working then?
He has CML, so he's just on the medication. So he takes a daily medication for the next 5 years.
Oh, okay. This one was the Hirschsprungs. This is the one where that part of the bowel doesn't have the ganglionic cells, so it can't expand. So they remove that portion, give that temporary colostomy, and then when the child grows enough, they astomose them back together.
Okay.
So it was
So it will have a normal bowel movement.
no, the answer is I'm glad my child's ostomy is only temporary.
Okay.
They're not gonna have a normal bowel movement for a while because they're
Okay.
gonna have to have that colostomy. Cystic fibrosis was that sweat chloride test. Okay, I had to drop this one also. There were some that we didn't talk about, so all right, I dropped this one too. It should have been 100.
Okay.
but they said it was 110.
Yeah, the ATI, I think it was, said 90 to 110.
Wow, and we said 100 in class. So I just dropped it. I'm like, oh, this is weird. So you did get a point for that one. Okay. This is Candidus, oral thrush.
Okay.
White milky plaque that does not come off. And remember, with steroids, yeast infections are common. So you really didn't do that bad, because of the ones I had to drop. So I think it basically was just that you didn't have time to study.
Yeah, I believe that too, and I wasn't feeling well because of all my stress from everything. So
Yeah,
I
yeah.
think that was a big play and
So I
everything.
don't think you're going to have a problem with the final, and you're not going to have a problem passing the class.
Okay.
All right. Have a good day.
Thank you. Bye.
Now I got to get back to her.